Thank you ever so much. Our next speaker is Dr. James Perrin, who is well known to the Academy. He will address practice transformation, mastering the new environment of pediatric practice. Dr. Perrin served as our organization's president in 2014 and has a long record of AAP service by chairing many AAP committees and work groups. He is a primary care pediatrician with a lifetime of policy work and advocacy for children and adolescents, especially those with chronic conditions. A professor of pediatrics at Harvard Medical School, Dr. Perrin formerly headed the Division of General Pediatrics at the Mass General Hospital for Children. Dr. Perrin was also president of the Ambulatory Pediatric Association and founded its journal, Academic Pediatrics. Please join me in welcoming Dr. James Perrin.
Thanks. Thank you, Milton. Thank you all for being here today and following on Andy's really wonderful presentation. I think what I'm going to talk about is practice change and how do we sort of take some of these ideas and put them into practice. I have no disclosures or conflicts of interest. So why are we talking about practice change? Why aren't we doing just what we're doing so well and staying with it? Well, there are many things going on. One is, of course, the soaring costs in healthcare that is really eating up funds from almost all other sectors. We're really squeezing the budgets that are available for any other kind of domestic policy in this country because of the growth of healthcare expenditures. Now, you know, we as pediatricians are not responsible for that. We are not major players in this vast growth of healthcare expenditures, but it is driving a lot of the interest in practice change around the country at the moment. And it is worth knowing that even for children, the growth in healthcare expenditures has replaced funds available for growth in education and other services that are really critical for the young people we're concerned about. But from the level of pediatrics, we're also really very positively addressing our greater recognition of the mental and behavioral needs of children, the social determinants of health, the influences of community on health and development of children, the critical role of prevention, something we've always stood for. And our priorities at the Academy have included issues like poverty, early brain and child development, epigenetics, nutrition, immigrant health, abuse. I could list others that we're really deeply passionate and committed to. And these are also things that are driving our commitment to practice change. What else drives practice change? Well, the passage of the Affordable Care Act now several years ago codified the triple aim, the notion of improved care, better health at lower cost. Now again, we're not the big cost drivers, but nonetheless, that is the triple aim here. And has really talked about the notion of value-based payment and population health. I'm going to get into both of those a little bit later. But we're also seeing tremendous changes in consumer demands. They too were asking for lower cost, increased access and convenience. We're also seeing changing healthcare markets around us, partly driven by consumer demands, the growth of new technologies, some of them disruptive, things like acute care clinics, telehealth, both in our practices and external to our practices. But most importantly, AAP members are increasingly working to address new pediatric priorities. Let me spend a couple minutes on the issues of payment and population health. Certainly, we're moving from fee-for-service to something else. I'm not quite sure that we know what something else is yet, but the current buzzwords are pay for value and population-based payments, so moving in that direction. But let me ask you, do you know what value is in pediatrics? Do we know exactly what we're talking about here? It's a tremendous opportunity for this organization to be out there very clear saying what we believe value in pediatrics is, and state that need. And a lot of people will listen to us as we do that. We're obviously interested in payment for prevention as part of what we are asking for in payment. And don't think this is just a problem for us. I mean, you know, Quite frankly, we pay for payment for prevention for 50-year-olds who are hypertensive, and the payoff is not in 18 to 36 months. It's 10 to 15 to 20 years down the line. So that notion of prevention is something that is ingrained in some aspects of payment. We want it to work for child health as well. We're increasingly being asked to be accountable for the health of populations, and pediatric population health addresses prevention again, and the mental, developmental, and psychological health of children. Now, think about it. That's almost the mission of the statement of the American Academy of Pediatrics. But importantly, only 12% of physicians today report receiving value-based payments for over 50% of their patients. So I'm not sure where we're going, except we need to be prepared in the pediatric community for what comes down the pike, and in fact, we need to suggest what the kind of motors are that come down the pike. Let me move briefly to Medicaid and private payers. We had this wonderful fix in the Affordable Care Act, but it only lasted 2 years. That was the Medicaid payment equity. It was only in primary care. That is to say, under the Affordable Care Act, we valued children with chronic conditions at 2/3 the level of how we valued children without chronic conditions. But now we've come down to be equitable, so all kids are considered to be worth 2/3 that of adults in the payment arrangement. And even though we will continue to fight this, I think it is really very little congressional interest in resuming the payment equity. We're going to need to find some other ways of really working here. And what we're facing in the Medicaid realm, and frankly in private payers as well, the notion of limited new dollars and the real push today to show value. Medicaid in many states is moving to new payment arrangements. Accountable care organizations in New York and Massachusetts. Many states are actually emphasizing social determinants of health and some prevention, but the notion of social determinants of health is often recognizing that the frail elderly that use emergency rooms and hospital beds need some attention to their social needs as well. We need to help those Medicaid directors recognize that we have social determinants up the wazoo for child health as well. There are some new funds in Medicaid through something called DSRIP. You all know what DSRIP is? It's the, I lost the D again, but it's the systems, delivery systems reform incentive payments. And these are coming now in 6 states, but they're going to likely come in a number of other states as well. Opportunities for you and your practices to make some changes in organization and incentive arrangements. There is also substantial consolidation in the private payer market, with again a good deal of interest in defining value. And if we could say to them, value in child health is this, they're very likely to listen. All right, let me move on from payment to what's happening in the consumer market. So care is increasingly consumer driven. Our parents of our kids would like information and access now via smartphones, video visits. To a degree, primary care and chronic disease management have led the way in the development of especially mHealth, where consumers now can access phone-connected otoscopes, activity trackers, scales, health apps. Patients with chronic conditions go home with connected pacers and monitors and glucose trackers. Health plans are embracing technology to drive down costs, and employers are embracing technology to engage employees. New wellness programs, chronic disease management. Other aspects of changing technology and services, consumers are driving the adoption, especially of disruptive innovations. So retail-based clinics, the percentage of consumers visiting retail clinics increased from about 10% in 2007 to more than 1/3 in 2015. Almost 60% of millennials prefer getting their health care from a retail-based clinic than a physician's office. In telehealth, 71% of millennials, now these again are the parents of our patients, want providers to use mobile apps for appointments. 60% support the use of telehealth options over inpatient visits. Much telehealth use is going on now on mental and behavioral health. So these are, again, are changes in the environment that we should be able to make use of to improve our practices. Some of our friends have joined actively with some of these disruptive innovators. We should decide what the American Academy of Pediatrics can do. Let me move on to changes in our own member needs. Our early career physicians, you really value work-life balance, have somewhat less interest in autonomy. You're highly experienced in new technologies. Most of you are starting in salaried practice, and most of you really do need leadership skills to advocate for children, especially in larger organizations. Our members in smaller practices are facing a huge change in the environment with limited resources. And those of you in larger group practices are facing the issues of how do you get resources for pediatrics. So we're trying to train you in leadership roles in that area. Subspecialists, there are fewer of you coming into the area of subspecialty pediatrics. We need more of you, and we need to leverage opportunities in this new environment to meet patient needs and attract new pediatricians into subspecialty care. Excuse me. So what do pediatricians do? Angie Rodriguez, she's in a for pediatrician practice in a small town in a changing neighborhood. There's a new Walmart's in town. She had a catch grant to let her add staff to link families with community services. She's part of a new community integrated network providing quality and practice change coaching. She and her 3 partners developed a prospective budget and decided to reallocate their new hire dollars to a nurse manager for chronic conditions. And the state behavioral health initiative co-located a psychiatric social worker 2 days a week in her practice. Phyllis Al-Halabi has been 8 years in this residency. She's in a much larger practice. They've built effective relationships between pediatrics and internal medicine and family medicine. She's had leadership training to advocate for pediatric needs in her multi-specialty group. What general initiatives need a pediatric component, and how to define and advocate for pediatric-specific issues. Her practice is active in telehealth. I have a few other innovators here, but I think I'm going to move on and talk about our view, to a degree, the pediatric practice of the future, and hope that you'll help those of us working in this area all together to see what we can do to make this the right vision for where we're going. I think we see pediatricians leading multidisciplinary teams organized to address population needs. Prevention and assessment. Substantial amounts of the identification and management of common acute self-limited conditions delegated to non-physician staff. Physicians involved very much in the prospective management of chronic conditions, diminishing secondary disability, and really highly integrated mental and behavioral health. This is really bringing us back, for some of us, to our roots, but the opportunity now to become far more capable of dealing with early identification, prevention, and treatment of some mental and behavioral health issues is kind of critical. The practice will have mHealth and telehealth highly integrated, working in prevention, monitoring chronic disease, dealing with mental and behavioral health. It's a great method for providing these kinds of services and encouraging healthy behaviors. And the practice will be integrated with other community services with attention to social determinants of health. And importantly, the practice will have data, not easy to get these days, but we're all working on it, data and payment that support population health and longitudinal care. What does team care in the pediatric medical home look like? And many of our colleagues, many of you in the room are already doing this. It's a practice leader, a pediatrician at the center, someone really dealing with chronic care coordination, often but not always a nurse who helps to manage the kids with asthma, diabetes, etc. Some integration of mental health treatment and support, perhaps through co-located mental health providers in the practice. Attention to early brain and child development, at times working with some of our colleagues in the home visiting area, but other strategies for doing this as well. And then someone in the practice to help link families with community resources. This is the kind of team that we're working to, and many of our members, many of you here, are already doing elements of this. And parents, of course, are partners in team care. Let me end my talk with a little bit of description of the work of the Task Force on Pediatric Practice Change. You'll be hearing shortly from my good friend and colleague, Ann Edwards. who's an absolutely phenomenal pediatrician whom I learned a tremendous amount from. So Ann and I have co-chaired this task force. We have membership from all aspects of the academy here. Some rather remarkable people have really been very active players here and helping to sort of bridge the gaps across what have traditionally been a little bit more siloed aspects of the academy that haven't necessarily talked with each other. One of the great benefits of the task force, people are really talking with each other with very different interests and backgrounds. It's been a wonderful group, and we're blessed with remarkable staff. When you can get staff like this, things will work incredibly well. Remarkable people there. The task force is working on several areas. We're developing resources for practice change to be available to our members. We're addressing some issues in population health and practice redesign. We're talking about payment and the measurement of value. We're working on new technologies and practice innovations, some disruptive. And we're trying to offer all of us, all of you, leadership skills to empower you to be more and more active and take leadership in assuring your own destiny in this very interesting changing environment. What are some of the resources for practice change? We have a glossary of terms on the website. By the way, I don't think we have Disrupt there yet, but we'll get it in there soon. There are many other terms that are kind of hard to know about, and we've tried to provide just that information for you. There's a lot of very good new AAP web contact. Examples are information on leading practice change, team-based care in the primary care office, quality improvement, alternate payment models. You can find all of these at aap.org/practice transformation. Please go there. Please make use of it. Please let your colleagues know about it. Please let us know what we could do different and better and what isn't there that you really need to do your work better. In the area of population health, again, we're trying to ensure that we have pediatric leadership at all levels, state government levels, federal levels, working in your larger group practices, in smaller communities, in CINs, that we have pediatric leadership at all levels to ensure that all children receive the care they need in the changing environment. We're trying to access and use population-level data. Now, for Medicaid, which is a pretty big player for many of us, about 70 to 75% of Medicaid care today is being run through MCOs. And the sort of steps in the chain of where data are and may be accessible is a big issue for us all to be working on, and we're really trying to work at that level too. Team-based care, I've talked about several times in this talk. We have a policy statement that's in development about team-based care that I hope you will find really interesting and really helpful in our growth in this area. It should be available in the next several months' time. Let me move on to health system and payment reform. We held a pediatric ACO summit about a year ago in Elk Grove Village. There's a summary of that on aap.org, chock full of really information about what worked and didn't work in the 5 ACOs that we looked at very carefully. There's a supplement in press in the journal Pediatrics on value-based care. This, I think, will help us make some progress to saying what is value in child health care. We've had a quality measurement summit and a mass work group which really came together to develop some consensus on a small number of measures and what pediatricians want to be measured on. This is a real step, but it's only a step in a process that needs to continue so that we do end up with the right kinds of measures to say that all of our payers are asking the same questions and that we as pediatricians think these are the right things to be measured on. It'll be interesting to see how this develops because we may be talking about really new measures. For example, school readiness at age 5, literacy at age 8. These are not traditional pediatric measures. We may be going there. We're planning a Medicaid summit, and our goal is to make Medicaid work for children and pediatricians, and we're developing new Medicaid collaborations as well. In the area of technology and practice innovations, we have a great team of people partly led through our very, very strong section on telehealth care that's monitoring technology and trying to support practices as you implement some of the new technologies, especially telehealth. We have a couple of really good statements in telemedicine. We have some distance learning programs through our project ECHO. We're working on trying to make health IT really work for pediatric practices. We're trying to take some attention to mHealth developments in child health care, so again, we can provide members with good information on what might be really helpful to you in your practices. We have a section on telehealth consult service, so you can actually get advice from one of our members to tell you, if you're interested in getting started in telehealth in your practice, this is what you can do. And of course, we're already doing a lot of work to link primary care and subspecialty pediatrics via telehealth. And in fact, the Project ECHO program is an example of that that's really working very well. But in the changing provider landscape, we're also talking about retail-based clinics. We're revising our current retail-based clinic statement to cover acute care services. We want to identify a clear AAP strategy for work with acute care services. And finally, in leadership skills, we're trying to provide communications to all of our members, the AAP News. We have a new project in leadership development for young pediatricians. Change management and resilience are critical to where we go. Our task force aims to develop tools and resources that address each of these areas: practice transformation, optimal child health, and clinician well-being. Thank you very much.